Our panel has organized a set of ideas. I want to begin with, first of all, just the notion of trust, and then I'll introduce the program and the participants. All my life, and I would imagine for many of you, we hear a lot about employee voice and worker voice, citizen voice, people's voice. And we're certainly going through a period of time in our history now where the issue of the voice of people is perhaps front and center as never before. As many of you, I think, would agree, I think by and large, the skill, the experience, the knowledge, the emotion, and the intellect of most people is not something that is actually mobilized in people's lives in ways that actually contribute to or are asked to contribute to problems that we face, whether it's in their community or in the workplace. So today we are going to share some practical examples and some theory about what we mean by at least one set of systems that we believe can enable employee voice in real problem solving in a context of shared purpose. We're not talking about problem solving someone else's problem on their behalf. We're really talking about mobilizing employee voice and participation in solving problems that have a common basis of purpose and support. Trying to move the slide here. It's not moving. There we are. So our presentation today will have first a presentation by two doctors from the New York Health and Hospitals system and members of Doctors Council SEIU. They are part of the Union of Doctors in the United States, which, as many of you know, it's quite rare for doctors to be unionized. Doctors Council is the largest union of doctors in the country. And we'll be hearing from two doctors who have helped organize and participate in their collaboration councils in their hospitals. We'll then hear a presentation from Professor Charles Heckscher from Rutgers and Professor Paul Adler from USC, who will be providing another practical example of what we call a collaborative community and some theory in support of that work. We'll try to leave time for some open discussion. As I said at the top of this discussion today, we're living in a time where I think all of us understand that we are at a true inflection point in our history. We must have a reorganization of our society that meets people's needs. Certainly when we think about the labor movement, we know that we've had a long history that has resulted in some great success through history of mass organizing and strikes, which I happen to believe needs to go on. We've also had various forms of the creation of a broad social vision, and we need that more than ever. But what we're going to address today is a third path, which I often say is something we could do today, tomorrow. We don't have to wait. And that is, how do we create transformation in our workplaces? Our panel will explore that subject in two areas of our economy and our society, which actually have millions of unionized workers who work in a labor management setting every day, healthcare and schools. So just for a brief introduction, what are the collaboration councils at New York Health and Hospitals, the nation's largest public health system? They were established in 2015 collective bargaining between the Doctors Council Union and the health system. And they function to enhance communication and understanding between frontline doctors and their executives. And how do we define a collaborative community? Well, taking from the work of Paul Adler and Charles Heckscher, Lawrence Prusak and others, we really are defining a collaborative community very specifically. And that is that we are searching for the kind of organizational system that can marry a sense of common purpose to a supportive structure. And in these organizations, they mobilize workers' knowledge and talents and expertise in flexible, highly manageable work group efforts. That's our definition of a collaborative community. With that, I want to introduce our first speaker, who I'm privileged to have known for some time, Dr. Gul Bakhtiar, a distinguished frontline doctor and, as you see, professor of medicine at NYU. She's an endocrinologist, and I will let her share her story with you. Dr. Bakhtiar.
Thank you very much, John. So I'm ready to share my screen. Okay, going back. There is this.
Have something in front of the.
Something in front, right? So I will stop share and then share again. Okay. All right. Good afternoon, everyone. And thank you, John, for the opportunity. Thank you for the introduction. I am a frontline provider working as an endocrinologist at Woodhull Medical Center, which is one of the acute care facility of Health and Hospital Corporation in New York City. Woodhull is located in North Brooklyn and serves mainly to Hispanic and African American community, regardless of their ability to pay or citizenship status since 1982. In 2009, NYU took over and affiliation was established between the city, NYU, and Woodhull. This is a public and a teaching hospital with a residency program. Every year, many of our residents pursue successful careers as primary care physicians or hospitalists, or go in fellowships at prestigious programs. I joined to Woodhull in 2005 after completing my fellowship at Downstate Medical Center, and established Woodhull as one of the rotating hospitals of Downstate Endocrine Fellowship Program. Since then, I've been very active in patient care, medical students, residents, fellows education, and also contributed to any opportunity there is for more improvement in patient care and community. One last word about Woodhull is that there is 700-foot-long Keith Haring mural, which features his trademark dancing figures he painted in 1986 during AIDS epidemic. And in year 2002, the murals have been restored, and Woodhull established an artist access program, which allows the artists and performers to trade their creative service for medical care. Today, I was asked to talk about why collaboration councils are important to me, and why am I committed to the collaboration councils? Well, because I believe in our mission, which is to deliver high quality health service with compassion, dignity, and respect to all without exception, because I care. And the next question is how to achieve our mission that requires all the stakeholders, doctors, employees, and H&H leadership to collaborate for the same goal. I've been part of Doctors Council as an active delegate for the last 10 years. And I remember the numerous meetings we had with H&H leaderships to deliver the doctor's voice where we were not being listened to. And we were there to tell them that based on extensive surveys done in 2013 to 2014, over 96% of the doctors believe that they have a responsibility to take a lead and have a voice in quality improvement work. And over 80% of the doctors said they would engage in quality improvement activities if they had a voice to have a meaningful role. Again, over 80% of doctors said they were not consulted by management or asked for input in areas of healthcare management. By then, doctors' morale and patient satisfaction were very low. Doctors were resentful and had less interest in committing to implement the actions they were told to do so. During one of those meetings, I shared one of my experience with the leadership. As part of quality improvement in patient care, administration required doctors, nurses, other disciplines to participate rapid improvement events, one after another. We were just told to do so as part of top-down management. And as an endocrinologist, I was assigned to participate in RIE to improve diabetes care. After long work hours for days, we created a diabetes care booklet for our patients' use. Like any other RIEs, the results were presented, and like many of them, the action plan disappeared before implementation. After 6 months or so, there were no mention of this work, no booklet available for our patients. And administration had no idea about this unwillingness of the staff participation to those mandatory events, which was set for failure. Our demand for meaningful involvement in quality improvement and decision-making was heard only after numerous actions we took. We circulated petitions to H&H leadership and affiliates signed by over 1,000 doctors. We ran subway, newspaper, and radio advertisements. We met with the community groups and elected leaders at the city and state level, and we had a rally at Woodhall in Brooklyn. And finally, in 2015, H&H leadership and doctors' councils agreed on our demands for fulfilling the goal and mission of our mutual interests, which is to make H&H the provider's choice and patient's choice. We were able to create a bottom-up management, and none of these would have happened without Doctors' Council hard work to unify the doctors. I would like to acknowledge Kevin Collins, Dr. Prosha, Dr. Turkman, and Dr. Hurley is no longer with us from Doctors' Council. Since the establishment of the Collaboration Council, along with the new H&H leadership, my colleagues and I feel empowered and supported. Doctors, PAs, MPs, nurses, midwives meet with hospital administration once a month to share any barriers to practice best patient care and ask for a solution, actually be part of the solution. If issues are feasible to fix right away, we name them just do it. If not, we turn those issues into quality improvement projects and with voluntary participation. We have been quite productive and completed many FBCC projects, and the FBCC became a standing committee and listed in the bylaw rules and regulations in January 2021. And you can see our agenda from our latest meeting that all the leadership meets with us and they give us updates, and then we open the session for any discussion that comes from the frontline workers. Now we have a voice and it matters. Now we became the real advocates for our patients and we are able to make a difference. As an example of what an engaged group of providers can accomplish for their patients and community, I will share this event organized in November 2019 on World Diabetes Day. We created a day of recognition and testimonial for our patients. The aim was to empower our patients and their families through communication and education, as well as introduce them to diabetes technology. Representatives of companies lined up to meet with our patients to introduce their products like insulin pumps or continuous glucose monitors so that patients can have a voice and a choice in their medical treatment. We believe that insulin pump or continuous glucose monitor use is not a privilege, but a human right. With adequate and sustained support, everyone can utilize diabetes technology, regardless of socioeconomic or educational status. Our keynote speaker was Brooklyn Borough President Eric Adams, whose life story resonated with many of our patients. It was clearly a day of unity and care, where we were able to make a difference in our patients as well as staff life. So in conclusion, I became a doctor to help and support people in need. I treat patients and their families the way I would like my parents to be treated. I cherish respect to one another, compassion and care, and I do my best to improve my patients' quality of life, no matter who they are, what they do, or where they come from. Now that I know I have a voice in the matter, I'm fully engaged to make a positive difference in people's lives. So when I was asked why the collaboration councils are important to me, my answer is because I care like you do. So I want to thank John August for the opportunity to tell my experience, and thanks to Doctors Council, Health and Hospital Corporation, as well as all my colleagues for the collaboration. Now I will ask my colleague, Dr. Philibert from Jacobi Medical Center, to share his experience.
Don, you're muted. We can't hear you.
I think you're on mute, Don. Right.
Thank you. Okay. Good afternoon, everyone. My name is Dr. Donald Philibert. Thank you for the introduction. I am an obstetrician gynecologist at Jacobi Medical Center. We are a New York City Health and Hospitals institution, now with a joint license with North Central Bronx Hospital. So we take care of a wonderfully diverse group of immigrants and people who have been in the Bronx community for generations. It makes for, at least personally, for great professional satisfaction to be able to have that exposure to such a rich and diverse community and to serve them. And I do speak from personal experience, you know, as an immigrant. Sometimes I see myself in the patients, or, you know, my parents' experience as I see this hardworking community go through the, you know, the ups and the downs. So with that common thread of diversity, one of the beautiful things that we've seen with our collaboration council, and one of the treasures that I see in it, is the opportunity to get outside of your department. So we tend to work in silos sometimes within our hospitals and our units, but there's so much to learn from seeing what similar struggles different departments go through, and not just different departments amongst physicians, but also to have the experience of, say, our chief nursing officer telling us about what nurses are doing and the amazing work that they're doing. And it gives a different perspective. So in this picture, you know, I think this is wonderful. I think this really embodies what we're trying to project. And that is that if you look to all the way to what's to me is the right, you have our chief quality officer. Now, education as to quality improvement is not something we've necessarily learned as physicians in medical school. So we have a physician who's our chief quality officer, who's invested a lot in quality education and is present at our meetings and is helping us because we see the problems as frontline providers, but we don't necessarily have the tools to make quality improvement and data, and know about data analysis and how to construct a project. So it's wonderful to have someone like that at the table. And then next to her, we have Dr. Zinnemann, our chief medical officer. And we've forged a relationship over the past 8 years with this collaboration council. And we have Dr. Han, who has pretty much helped really create it. for us, and and really represented well the hospitalists and medicine. And next to him, we have Chief Nursing Officer. I won't go through everyone, but I just wanted to give an idea, give you an idea as to the representation. The only other person that I really want to mention is in the corner, the person with Jay Dean with the glasses and the beard and the checkered shirt. That's the union representative who's present at meetings, and when it's virtually present. And to have that vigilance from the union in making sure that doctors have their voices heard is wonderful. Now, what goes on at this table is, I think, very unique. We had, as a group, we had presenters, we had spoke about this. It's really amazing that we have this, physicians don't necessarily have a lot of union representation when you look nationwide. So when you have this opportunity to have a union step up and really advocate for the frontline providers to be the ones to say, hey, we see this day in, day out, and this seems like an easy fix. And maybe we've gone through our normal chain of command, but we can't quite make it work. That top-down approach is not working. So maybe with this bi-directional communication, we can have better problem solving. And it's been a wonderful relationship. And the next thing, and again, this is another representation as to who's at the table. The Doctors Council rep, the C-suite. We have a 2-hour representative who helps with the quality improvement and has protected time to help work supporting frontline providers who want to work on a quality improvement. Diversity in department representation as well. And we actually appreciate central office's representation and helping us with our data analysis and our quality improvement projects. So as things build, I think one thing that's been nice is we're at a place where we have a good problem, I think. And that's, you have so many people who are passionate, especially amongst physicians, and really want their voices to be heard and really want their projects to be put forward. And we look within our group, and we've looked to take these projects and how to stratify them and do the ones that, especially if we look at, we want to be timely about things as well. We looked at these projects during COVID, now looking at things hopefully post-COVID. And we're trying to use that to help stratify which projects should be pushed to the forefront. And I think that's one of our lessons learned. Other things that we've learned is service reports have been excellent. I think to give agency to frontline providers to speak directly to the C-suite. We've also learned that sometimes that 2 hours goes really quickly, and it might be better if we want to talk about a different project that we can email beforehand and have our C-suite representatives take a look at the different department reports and see what's going on and can give thoughtful responses if we're not going to talk about it every department issue at that meeting. And of course, we always have to encourage people to go through the normal chain of commands, and if it's not working, then we can bring this project forward, or it's like or something that we say low-hanging fruit, an easy fix. The other thing, one of the wonderful things that I think we've had in our Jacoby's facility-based collaboration council has been a centralized data bank. So our minutes are kept there. We've put all of our projects there. It's open for everyone to look at and learn from. And we hope to move that. Of course, I actually think it's already underway within a central office, so within New York City Health and Hospitals. And as we learn about, as physicians, like I said, I didn't go to medical school to learn how to do quality improvement projects. So to have these lessons and build an educational library to help people who are also coming behind us that are passionate about doing quality improvement, that's been a good improvement and something that I'd like to share as a lesson learned. I remember our first chairperson before I became co-chair of the council with Dr. Stephen Hahn was Dr. Maria Castaldi, who did patient satisfaction when a survey was done to see about actually patient satisfaction regarding thrombolic events. So patients had this opportunity to know, hey, we're really looking forward to decrease blood clots for you, to keep you safe. And I think that was one of examples of a wonderful project where surgery came together with our our COO, and our chief nursing officer, and the surgical chief as well for nursing for the OR. And it was a wonderful collaboration of all these different services that were able to show that there was a proactive movement to decrease blood clots for surgical patients, and showed how by making that really transparent with patients, that it actually improved their patient experience. So I would just want to give a big thanks to our Jacobi Facility-Based Collaboration Council in the Bronx. Doctors Council it's been wonderful to be a representative for Doctors Council, to represent my fellow colleagues and to advocate for them. So many things have happened that really couldn't have happened without the union. So I really appreciate them advocating for us. And Albert Einstein College of Medicine, I'm an assistant professor there, and we appreciate their support for us. And John August, thank you for involving me in this project. Dr. Hahn is the co-chair and really has been really more of the founder of things. So I can't have this presentation without acknowledging him. Dr. Malhotra has been our 2-hour representative and very she's been a mentor to me in quality improvement projects. Dr. Bajav's our CQO, Dr. Zinneman, our CMO, Jordana Bailey, our COO, and Chris Mastromano, our CEO. I really took that long list of people to thank, because the bidirectional communication has been so important. Building these relationships with these people over the years has been so important. So thank you.
Thank you, Don. Thank you so much. Now we'll transition to our distinguished academic leaders and thinkers. Let me turn it over to Professor Charles Heckscher of Rutgers. Charles, you're on mute.
Okay, there we go. Now I've got to present this again. I was doing well, except for the mute problem. The presentation thing is hiding under here. And I'm back. So thank you all. So I'm just going to talk very practically about about a similar case of collaborative counsel and structure and so on, but in a very different industry in schools in New Jersey. This is a project that's been going about 6 years. It's really animated by and driven by my colleague Saul Rubenstein at Rutgers, but I've been working with him along with John McCarthy, who is now at Cornell, over that time. It's trying to build essentially collaborative community within school districts in New Jersey. That's the core of the project, though we're beginning to spread beyond that. So this began about 6 years ago, 6.5 years ago, really with research, which goes back more than a decade, done by Saul Rubenstein and John McCarthy. And I'm not going to go through this research at all, but the takeaway, when Saul has made presentations about it, has been, and that has really motivated and excited school leaders, is that by building collaboration, you can improve student achievement. And Saul and John have demonstrated this through rigorous studies across the country. So that takeaway was brought, this is the history of the project, back in 2016, I believe it was, maybe late 2015, we had a meeting of leaders of the state associations. That's where it started. It didn't start from the government. It didn't start from the top in any way. It started from the state association, that is to say the School Boards Association, the Principals Association, the administrators, and a couple of others, and the principal unions of the state, especially the NJEA, came together and reviewed this research, and we're excited by the conclusions and committed to the idea of trying to build collaborative systems in New Jersey. So the following year, 2016, we trained, we held workshops for 3 districts, which are still very active today and are continuing to develop and are highly committed. The 3 districts that began their collaborative work. We've done a few districts each year since then, not last year, but most years. And we now have 23 districts active throughout the state who are developing this collaborative model, which I will describe. We've recently taken on some large urban districts, which presents a new challenge, and a whole new crop of them are coming on board this year. So just recently, within the last year, we've been getting a lot of support from the top. That is, first of all, the National Education Association at the national level has committed substantial funds and support for developing this New Jersey effort as a model for other states, and providing support for us, but also bringing people in from other states to learn. But Secretary of Labor Cardona, Governor Murphy, the National School Boards Association have all expressed strong support for this effort now. So we're beginning to get on the radar nationally. So let me describe a little bit how we do it. The basic core from fairly early on is when we work with a school district, we bring together for a 2-day workshop, typically, a group that's shared union and management group, leaders, administrators, teachers. And we do some skill building, we do some information sharing, we build some shared databases, but we really what our goal in that workshop is to start with projects. That is, we would like them to come out with some projects aimed at the furtherance of teaching and learning, the improvement of teaching and learning. So the 2 days really culminates in their defining some projects and some people that cross the organization to work on them. So some examples, at the beginning, they start with relatively simple projects, typically, sort of events to build the community, sometimes things like scheduling, which turn out to be rather difficult. As they go through the years, these projects become more and more ambitious. We've had districts, for example, among many examples, working on having teachers do peer observation and counseling for other teachers, looking at the grading system and the grading standards. And in the last year especially, a number of our districts have done extraordinary work with administrations in managing the logistics of adjusting to COVID and virtual education and all that, and also in developing materials and orientations to diversity and racial justice. So I'll describe the structure of the effort using on the left-hand column, there are the categories that Paul Adler and I have developed theoretically around collaborative community. Paul will get into the theory much more in a moment, but I'm going to just quickly describe what we've done in those terms. And starting at the bottom, we haven't done much with capabilities. I'm going to skip that because we just don't have time. But starting with authority, the authority structure, the standard authority structure has not changed. Right? So there are school boards, there's a superintendent, there's a superintendent's executive committee, there are principals, there's the union in its traditional role. That whole structure has not changed. The locus of authority for all those people, formal authority, is unchanged. But what we have done is add over that a kind of collaborative layer, so that in each case there are mechanisms, and both informal relations and formal mechanisms that bring in input to the authority structure, which was not there before, and therefore changes the decision-making process. So we have leadership teams at the school level and at the district level, which bring together the union and the management, and also teachers, board members, various stakeholder groups. And we have, in some cases, gotten direct involvement of the union in board discussions and board decision-making. So that's the authority level. At norms, which is basically the sort of non-authority relations and mechanisms, we focus around building, as I've mentioned, building projects that pull across the stovepipes, which Don mentioned earlier, the stovepipes of the organization and the levels, and pull people together around the shared purpose of improving teaching and learning. So we give a lot of discussion and training and so on around the mechanisms of organizing task forces and how to manage the data and so on. It's very much like the quality improvement work. And then at the level of values, which is our fourth category theoretically, it's interesting. We have from the beginning emphasized the basic purpose of improving teaching and learning. And that's very important because that's the shared orientation that everybody is looking to and is consensual. There are a lot of differences in what different stakeholders value, but that unites them. So that we focus on, but we don't from the beginning, at the beginning, go much further than that. We have not started, for example, by developing mission statements, elaborating mission statements. We start by starting work on the projects. And in the course of the projects, people elaborate, discuss their values, discuss their culture. And after a year or two, is a kind of just-in-time model of value development. After a year or two, when they feel the need, many of the districts start to write mission statements or compacts that help guide them further in the effort. So let me, here's just a brief, a picture of the structure developed by one of our member districts. So it's the picture that they use themselves to orient themselves. So the first piece of that picture is the standard hierarchy, right? There's the central office, the schools, and the classrooms, right? It's the standard hierarchy. That has not changed. But then there is the mechanisms I talked about earlier that kind of feed into that and overlay it. They have the district leadership team, the district committees that pull together people from the classrooms and interact with the district leadership team and that feed into the standard decision-making structure. And then they have on the right, which orients everybody, this purpose of improving teaching and learning with initiatives, what I've been calling projects or initiatives that pull everyone together at all levels and parts of the structure towards achieving that goal. So this is their orienting picture that they use within their district. And I think it captures pretty well what we're trying to do. The last thing I want to mention briefly is that I've described the structure within the districts, but the work beyond the district level is also extremely important. So we've pulled together districts in many ways. First of all, from the start, as I mentioned, the state associations, which link different stakeholders across the districts, have been crucial from the very beginning and very engaged and very supportive. So that we did not have support from the governor's office. We started in a Republican administration, which was not supportive. We did not have support from government, but these associations played the crucial role. It was just opportunistic, but we think that might be a good way to do it. We've built learning networks across the districts. So twice a year, all the districts come together and share their learnings and their best practices and talk about the leading edge problems that they're facing and share ideas about that. And then finally, we have a very interesting idea that's all developed really of peer facilitators, that is leaders from the initial few districts. So we have serve as facilitators and trainers for other districts. So they go out and help, or they run workshops, they help districts in trouble, they help with advice. So we've got principals, we've got union leaders, we've got a board member, we've got teachers, all serving as a network, as a core of peer facilitators. That's been a very powerful mechanism. So that's our structure, and that's the way we've gone about building collaborative community over these years. Thank you, and I'll pass it over to Paul, who will now give the theoretical case behind all this work.
Thanks, Charles. Let me jump into my little share screen and get us going here. I'll try to be as quick as I can and leave some more time for discussion. This is work that Charles and I have been engaged in with other collaborators over quite a few years now, trying to give some shape to what we think of as an emerging new form of organization we're calling collaborative, sort of capturing some of the wisdom of folks engaged in efforts around the country in different industries. I was planning to talk about some work I've been doing on collaborative forms of university organization. I'll encourage anyone who's interested in that to reach out afterwards, be happy to discuss it. But for now, what I wanted to do was focus us on what is the form of organization that we need in a time when workers of all kinds, from doctors down to the least qualified, are increasingly being drawn into tasks for which the term collaboration seems to fit. Collaboration in the sense that people are drawn into tasks where the ends, the goals, are not predefined. Part of the effort is to define the specific goals that we're pursuing and define the means by which we're going to pursue them. So neither the ends nor the means are known when we're in this collaboration work, and more workers seem to be drawn into such tasks with perhaps as a function of enterprises' desire to tap into the intelligence of their workforce, and also as a function of the changing external environment facing so many organizations where they realize they need the intelligence and initiative of more people in the organization. What form of organization can support this collaboration work? Here are 4 or 5 kind of archetypical types of organization with which you're all very familiar. I can give you some examples if you want, right? There's some organizations that are traditionalistic, that just replicate that make sacred their reliance on established practices. Hogwarts was the example I came up from the Harry Potter series, you might remember. McDonald's is an organization where the ends are very clear, but everyone's focus is directed to the means by which we're accomplishing those ends of very efficient production of low quality and low cost hamburgers. That's the bureaucratic model. You have other organizations that seem to fit in that box too, like Gore-Tex, that divides up the organization internally into quite independent little subunits that are each pursuing their own goals, right? The goals for each of them are very clear, right? Make money, right? And they're left to their own devices to work out the best means for doing that. But we're interested in organizations where people are engaged in consciously in reflecting on what are the ends to which their work is oriented. What is this project about? What do we need to do in our department in order to make our organization more effective? There are 2 ways of doing that. The way that people are more, 2 forms with which we are familiar. Apple under Steve Jobs relies on a charismatic form of engagement, right? To a leader that inspires and that inspires an emotional attachment. That's one powerful way of keeping people focused on that vision, that end purpose as articulated by the great leader. Academic departments on a good day, have that sense of a shared purpose. We all want to advance the state of knowledge. We all want to deliver high quality educational experiences, but we're not quite sure what that means in the context, right? We need to design courses. We need to develop research projects. And so we are focused on defining the ends collaboratively, right? And developing the right means, the right approach to reaching those goals. Neither of those get us where we need to go if the task of the organization is shifted in this direction of collaboration. Charisma is terrifically powerful. It can orchestrate lots of energy and make radical changes, but there's no rational discussion of purpose in such an organization. Everyone just bowed down to Steve Jobs' vision. And it's an form of organization renowned for its lack of cost effectiveness and efficiency. Collegiality in an academic department is all very nice. It achieves a pretty good level of innovation, and even on a good day, some sort of efficiency, but it's limited to a small scale where people share a common socialization in their professional kind of backgrounds. And so neither of these models really suffice as a way to think about what does it mean to have a hospital or a school system that operates collaboratively, that engages the creative problem-solving capacities that John August introduced the session focusing on, right? What does it mean to organize an entire complex organization around the shared purposes? Neither charisma nor collegiality, nor the combination of the two, gets us where we need to go. Our argument is that no, it's not inevitable that as we scale up these organizations, we degenerate into rigid bureaucracy. Right? We're very familiar with what happens when those more collegial or charismatic organizations scale up. They often degenerate along these 4 dimensions that we described before: fragmentation, goal displacement, centralization, specialization, silos. We think what's been happening over the last century is that a lot of creative people have been trying to develop techniques for scaling up this idea of a focus on the ends, right, and the means, right, thinking about them rationally as opposed to in the charismatic model, and engaging to building the organizational systems that can sustain that focus on shared purpose, rational engagement around that shared purpose at scale in complex organizations. This is just a list of some of the kinds of practices that we've encountered in different organizations that seem to be pursuing that collaboration task most effectively. To bring it back to some of the points that have been made in the session today, and relate them to the way that Charles and I have been trying to distill the underlying principles behind this multiplying portfolio of scaling techniques. You know, I could mention, I loved Gould's reference earlier at the beginning about where she says, I believe in the mission and I care about the mission. You know, that's a value commitment that is very precious, that these organizations rely on, that sense of shared purpose and that sense of, in the medical world, once upon a time, many doctors thought of themselves as captains of my own ship, right? Now we're team players. Enabling standardization comes through when folks realize that they need the apparatus of formal systems and procedures, but instead of having them being imposed on us from the top down, we need to work collaboratively to develop procedures and standards that enable us to do the work that fits the mission, that enables us to continually mobilize all that intelligence. We saw Don referring to the use of the SWOT technology as a tool for prioritizing the work of the committee, for example. Participative centralization seems a very common theme across all of these cases, where we heard Gould talking about the difference between the top-down model of setting these REI goals, right, and the collaborative model that they developed in the context of their work. I'd mentioned John August's work at Kaiser Permanente a few years back, where through a participative process, they articulated goals for the entire organization, Kaiser Permanente, of what best place to work, best clinical quality, best service quality, and most affordable. Right, those 4 overarching goals developed collaboratively between management and all the unions, right, that help set goals for the entire organization that were consistent, so that everyone is pulling in the same direction. And then finally, under integrative specialization, we saw in Don's presentation the power of bringing together the different skill sets of doctors with PAs, nurse practitioners, nurses and midwives, pooling their expertise, learning enough about each other's skill sets so that they can effectively work together and not just trust that the other person at the other end of the table is going to handle that aspect of the problem. So as I see it, as Don said, he said there was so much to learn when we bring everybody together in these teams that one's own skill set broadened. So just to wrap it up, as we see it, I think it's fair to say that there are enormous impediments facing the emergence of this collaborative form of organization. We battle against the inherited conditions, the existing management models, a top-down, bureaucratic, or market-oriented, or for that matter, charismatic, or collegial. Everyone's just focused on their little pocket of similarly minded folks, and the prevailing neoliberal public policy regime is not supportive of the new collaboration models we've been talking about. I should also say it's also pretty clear that our enterprises themselves embody contradictory goals, and it's not. And collaboration is in contest with some of the other goals of the business organization. But as I see it, and to pick up again on John's introductory comments, developing the collaborative form of organization, developing the practice of collaboration in our workplaces is a struggle. It's a front in the broader struggle of the workers' movement. And it's an exciting front because of 2 things.
It speaks to people's real needs for human development. It opens up possibilities for human development, but it also builds class capabilities. It builds a working class with a much richer cognitive repertoire, behavioral repertoire, a set of skills that opens them out and makes them agents of social change, that much more effective agents for social change. With that, I'll stop sharing and we can open up the discussion. Thank you.
Thanks so much to all of you. Let me just add one comment before we open it up for some questions. And my comment is this, that I think we know from experience and study that little kids, 2-year-olds to 6-year-olds in particular, go out on the playground every day or into their daycares or classrooms and solve problems better than any of us. And the reason for that is because there's really no hierarchy, there's really no organization, they don't have any choice. And they do it better than anyone. I believe and feel that if we actually were able to intentionally create organization and environment for workers and their colleagues to go to work every day and solve real problems with a shared purpose that benefits the community that they serve, be it public sector, private sector, community, and so on. If we actually enabled and organized people in that way, I believe we'd be living in a different kind of society, one that would be much more humane and much more trusting. And I don't believe that's high level at all, because I have the privilege of working with people every day, people like Charles and Paul, Don, Gul, who actually are working at it every day, and we see the results. With that, if there's any questions or comments from our audience, please feel free. You can put it in the chat, or you can just start talking. We have a few minutes left.
I have a question. This is Todd Dickey from Syracuse. Thank you all so much. Just really appreciated the intersection of theory and practice here. And, you know, it was talking about the distinction between kind of the rational and, you know, moving away from the charismatic. One of the things that I was thinking about, a question for Don and Gul, in terms of the 2015 collective bargaining agreement, it sounds like that was a kind of transformative moment. And I was wondering, the language that set up the collaboration councils is going to be really important, right? In rationalizing, you know, how they move forward. And I'm wondering if you could talk about, maybe each give an example real quick of one thing has really worked, and maybe one thing you would change if you could go back and unilaterally amend the collective bargaining agreement from 2015, because I think that could really hone in on some of what works and what doesn't. So I'd really appreciate that. And thanks again to everyone. It was excellent. Really enjoyed it.
Gul, you're muted.
Yeah, Dr. Bhatia, I'll defer to you first, please. Yeah.
Yes. So basically, I was part of the meetings, and absolutely, we were talking to them, and we were like, there was a big wall. Like, we weren't able to go into their world, and they were not willing to come to our world. So there was this big disconnect, and we didn't give up. I mean, we tried everything, and I remember myself being in front of the hospital, just screaming, rally, and I have a big picture of myself in Dr. Carlson's office. Whenever I walk in, I see my passion over there. We never gave up. What would I have done differently? It was just a collaborative work. We worked all along one another. Maybe we were quiet, we were afraid, we were scared. So I think that part, like, and all sharing of information about what we were actually doing, I think we reached out enough people. I don't think that I could have done anything differently. And today it's going really well. As Don said, our C group is so much involved, and it's become a part of the bylaws. So it's a committee that we have to run on a monthly basis, and everybody's there. And what I can do now is just to reach out to more people because the culture has to be changed. Still, the providers, some of them are not aware that they have a voice. So I'm telling that this is an opportunity, this is a platform for you to come and join us. I have to still work on that.
Don, anything you'd like to add?
Yes, thank you for your comments, Todd. They were appreciated. In terms of a specific example, it made me think a little bit about right now we're working on a project with the C-suite and actually with finance. And, we never brought the finance office into our meetings before with a collaborative meeting to learn about, with our new software system, how we generate revenue. And when, we click a button and it makes a big difference which button you click, but I think there's a little miscommunication and there's a little education gap that exists. And you have frontline providers who say, we're mission-driven doctors and our concern is, or really our first thought isn't really billing. We're thinking about giving patients the best care that they deserve. With the resources that we have. But yes, we're invested. We want to help keep the lights on. We want to help keep things in the black. So we need to be part of that process, and there needs to be communication with us, and we need to be involved in it. And I think that is one example where there's that investment that we have in the corporation. When I think back to the collaborative bargaining agreement, I think if you're investing in your physicians, and you have ongoing investment, part of that investment has to be education. And so I think that there should have been maybe a little bit more of a push for more continuing medical education and more of a pathway towards continuing education and continuing professional advancement. So I would think that could maybe be a little bit more robust.
Thanks, Don. Let me turn to David, who has his hand up. Thank you.
Hi, thank you very much for this panel. It's great to be here and hear all the presentations, both practical and theoretical. I have a question about whether or not in the business community there is support and reinforcement for the collaboration model. For a long time, as you know, there was a group called the National Planning Association, which brought together labor and management leaders, and it provided a forum for the reinforcement and celebration of collaborative models. That organization fell apart in the 1990s when Kaiser was complimented, was celebrated for its partnership, for its collaboration. It was a group called American Rights at Work that offered the celebration rather than a business-based institution. So what's happening in the business community, either to reinforce or to push back against effective models of collaboration? Thank you.
I could comment on that a bit. That's okay, John. Yeah, I would say that labor management cooperation has definitely been on decline in the business community, partly because, or largely because, unions have been on the decliners linked to that, so that they have less power and therefore less ability to push their side. The broader concept of collaboration, of bringing in, of creating mechanisms for involvement of multiple levels and multiple stakeholders are still very much active and under development. It's, I think, in all parts of the economy, and even in places like Walmart, if you go not on the front line, if you go up into management, you find a lot of these participative task forces and fluid teams and all this kind of stuff. And that set of mechanisms and a lot of invention about how to do it has continued to develop over time.
But if I can add, perhaps, in response to your question, David, it's such a terrific question. I've become increasingly aware of the importance of the sort of public policy context, the power of government and the state apparatus to encourage or discourage moves in this direction. And I do think there are all sorts of ways in which we might be hopeful that the Biden administration starts tilting the playing field, or in favor of collaboration, shall we say. There's not just in reforming labor laws, but there's a whole range of other legal and regulatory factors that lean in the direction of this more neoliberal direction, neoliberal practices at the firm level that militate against collaboration. So I'm modestly optimistic, as many of us are, that with the Biden administration, we might see the beginning of some turnaround in public policy that would give more space, more runway to the business community embracing collaboration as a model.
Thank you, Charles and Paul, for that. Appreciate it.
Well, thanks to everyone. I think we're close to being out of time. I'll try to get the last word here, if I might. First of all, I just want to really thank my co-panelists, who are people that I've had the pleasure of getting to know, who are just so inspiring through their work over many, many decades in some cases, and more recently among the doctors. But first of all, just want to say that. Finally, I just want to say that I ask all the time, and some of the very esteemed faculty I work with at Cornell, who've been studying and actually been great theoreticians in the notion of transformative labor relations. They're asking the question all the time, why is there not more of this work being done? Because everywhere it's tried, it makes sense. And quite frankly, where there's intentional support, it works. And it does create improvement for communities and for the people involved. I'm not sure I have the answer, but I do know that for people who are exposing themselves to these organizational practices, I encourage you to do more of that, learn from it, and become advocates for this work. Without it, I think it's going to be very difficult for worker voice to actually, on its own, be able to deal with the current state of the world, given technology, given trade, given all the things that we're facing. Starting with a collaborative community in the workplace, I think, is a great foundation for the future. Anyway, thanks so much to Lyra again, and thanks to all of you. Be well.
Thanks, everyone.
Thank you.
Hi, everyone. If you want to join us on the plenary stream, our National Policy Forum plenary is getting ready to start.